US-guided biliary drainage is an effective palliative treatment in patients with malignant distal biliary obstruction following unsuccessful ERCP. In cases of impractical or unsuccessful US-guided bile duct drainage, US-guided gallbladder drainage is an effective alternative technique in the setting of patients. The use of an electrocautery-enhanced lumen-apposing metal stent allows a one-step, exchange-free procedure. We present a case of a 70-year-old woman with jaundice who was diagnosed with unresectable malignant distal biliary stricture. The patient was referred to our hospital for palliative biliary drainage, but the ERCP failed due to papillary and duodenal infiltration. We then decided to perform a same-session US-guided biliary drainage. Choledochoduodenostomy was impractical due to the presence of vessels between common bile duct and the transducer. We then performed a cholecystogastrostomy by placing an 8x8 mm electrocautery-enhanced lumen-apposing metal stent in a freehand fashion. However, after 1 month, the patient complained of a jaundice relapse and was scheduled for an endoscopic control that revealed the proximal flange of the stent completely buried in the gastric wall. Endoscopically, a 2 mm fistulous orifice is visible on the covering tissue overgrowth. US examination confirmed that the proximal flange was within the gastric wall. Hypoechoic gastric masseter layer is well visible and distal flange is in place into the gallbladder. With a linear echoendoscope, a bending cannula was smoothly inserted through the fistula into the buried LAMS under combined fluoroscopy. Injection of contrast revealed the distended gallbladder with a patent cystic duct and slightly dilated intrahepatic biliary tree. No contrast leakage was revealed, confirming that the distal flange was correctly in place. An O35 guide wire was then passed through the cannula and coil into the gallbladder. The delivery catheter of a 10 by 10 mm electrocautery-tipped lumen-apposing metal stent was advanced over the wire into the gallbladder without any device energizing. Under fluoroscopy, the distal flange of the second LAMS was deployed into the gallbladder, beyond the distal flange of the buried LAMS. Under fluoroscopic guidance, we applied slight traction on the endoscope stent coupled system until the black marker on the stent delivery catheter was seen under endoscopic view. At that point, the proximal flange of the second LAMS was deployed into the gastric cavity. A through the LAMS in LAMS cholangiography confirmed that the stent was correctly in place without any contrast leakage. As you can see, the first LAMS is enhanced by the white arrows. The second LAMS, enhanced by the red dashed line, has both larger flanges and a longer body compared to the first LAMS. This ensures a perfect fitting of the two coaxial stents, as shown also at this final US image. Post-procedural course was uneventful and patient was discharged home the same day. Buried LAMS is a rare complication previously reported for various indications and managed when possible by endoscopic stent removal. It seems that motility in the gastric antrum results in more vigorous traction on the stent, producing an hypertrophic response on the gastric side. Removal of the buried stent is an invasive and technical demanding procedure that in the setting of biliary drainages increases the risk of bile leak and subsequent peritonitis. The described LAMS in LAMS rescue procedure allows the endoscopist to recreate a safe drainage conduit without the need to remove the buried stent.